Okay, everyone, we're going to go ahead and get started. My name is Madison Meadows, and I am with the Hub Learning Community, which is a transition support team based at Integral Care. I'm going to give some introductions and some instructions today before we get started with our presenter, and then we will turn it over to Jordan. So today we have part of our speaker series. And we are focusing this month on developmental disability awareness. And so that is kind of the theme that we have and the focus and intent of our presentation today. Because we are collecting information and data for the program, there will be sign-in sheets and evaluations. So please be on the lookout for those. I will be sending that information in the chat box. The chat box is disabled for participants throughout the presentation, but we will have Q&A available. You can see on the bottom menu that there's a Q&A box. You can enter in questions there throughout the presentation, and then we will go ahead and answer some of those during the live Q&A at the end of today. So please, again, if you have questions, thoughts, concerns, go ahead and put it in the Q&A. The chat will not be available, and if you raise your hand, we're also not going to be able to respond to that. So Q&A is your best bet. Today, I'm going to give you a little bit of information about our program, and then we'll get started. So the Transition Support Team is a program throughout the country. It's a federally funded program to support community living and prevent institutionalization for individuals with IDD. So through this program, we support professionals, staff in both the communities and local authority agencies in doing their best work through education, through case consults, and through something we call technical assistance, information, clinical referrals, that type of thing. So today we are focusing on education. So I'm going to go ahead and introduce our speakers so that we can get started. Please be on the lookout for some questions that we ask through our polling and also the evaluations that come at the end. In order to receive CEUs, you will need to stay until the end and fill out that evaluation. Okay, so without further delay, I'm going to introduce our speaker, Jordan Smelley. Jordan Smelley is a certified peer recovery support specialist with Young Peer Mentor endorsement here in Texas. He uses his lived experience with IDD, intellectual and developmental disabilities, and co-occurring mental health diagnoses to support and provide resources to others. Jordan shares his experience in hopes that others with IDD will not have to go through as much trauma as Jordan has in order to get the supports and resources needed to become a contributing member of the community at large. We are so grateful to have Jordan with us today. He has some great experience to share with us, and he is going to take over from here. So Jordan, feel free to take over with audio and video. Thanks so much.
Good afternoon, everyone. Like Madison said, my name is Jordan Smelley. I'm also now a mental health peer specialist as well. So I hold both the PRSS and the MHPS. All right, so key takeaways from today's full presentation. By the end of the presentation, you should have an understanding of how you say things to patients does affect their recovery. And for those of you who are peer specialists, as like myself, yes, we don't call them client or patients, we call them peers. So understanding how you say things, as a clinician can affect your patients, as well as how us as peer specialists say things to the peers we support can have an effect on their recovery. basic understanding of what peer support is and what a peer support specialist does, how individuals with IDD can benefit from receiving peer support services, and know where to go for more information on Texas Medicaid billable peer support certifications. So before I kind of start getting into my story, I kind of wanted to first share some pretty cool accomplishments that I've gotten, or opportunities that I've gotten to participate in since working on my recovery. So as some of you know, I serve on the Texas Behavioral Health Advisory Committee as the youth and young adult representative, as well as the current co-chair of the BHAC. I chair a subcommittee of the BHAC for peer and family partner services. Actually a published peer specialist on the blog for adolescents, the Center for Adolescent Studies in California. I did an article for them on working with youth with IDD and trauma. I've gotten to do some other presentations besides this one. And this is all because of finding the supports and resources I need and working hard on my recovery. So without further ado, I'll kind of get into a little bit of my story. So ages 18 to 26 were the darkest parts of my life. I was constantly in and out of inpatient and or intensive outpatient psychiatric treatment because of the lack of support I needed due to physical disabilities, mental health diagnosis, and intellectual and developmental disabilities. This was a time where I tried going to college, and from 2007 till 2013, and it was a major struggle for me because the supports I needed, they weren't available back during this time period. I know nowadays at colleges there's more support and help for those with mental health issues, but there wasn't much support back in 2007. Trying to navigate and get my needs met was extremely difficult. I actually didn't find out about intensive outpatient or partial hospitalization program until I was in crisis in college. Luckily, we had a certified LPC in the counselor's office where I was attending college. And I was talking to her that it's like, I need help, but it's like, I don't feel like I need to be hospitalized because I was in my last semester of college and I really wanted to finish and not have to keep continuing, because that was kind of one of the issues. Was I would get into the semester and then things would happen and I'd become overwhelmed and unable to cope, and then I would end up inpatient. So she helped me, and she helped me figure out that there are other options for me. So I actually ended up finishing college while in an intensive outpatient program, which was very helpful for me. The kind of the other struggles and is, I also suffered trauma from the way I was treated by some mental health providers during this time period. One example, and I won't mention which organization this was at, but at one organization I was receiving services from, I actually had a psychiatrist tell me that they were only seeing me just because I was just out of inpatient. And so, of course, I was a little more stable than when I was inpatient, but not stable enough for a psychiatrist to be telling me that just because you're out just getting out of the hospital, I'm seeing you today. So of course that sent me back into the hospital because, you know, I kind of felt like there was no hope for me. You know, obviously, you know, with the supports available, they just don't care about me. It was very traumatizing to have a professional tell me that they're only seeing me because I just got out of the hospital. Thankfully, though, I had an awesome caseworker, and she intervened and got it to where I could see a private psychiatrist from my insurance, but still get case management services and peer support through them, even though I wasn't seeing one of their psychiatrists. So that did help. Another time, I was in an IOP program, and I was having an unusual side effect from a medication I was put on, and I reached out for help with my IOP therapist, and I told her what was going on with the new medicine, and she reached out to the psychiatrist, and he said that it was impossible for what I was experiencing to be a side effect. And so I got kicked out of the IOP program just because I was having issues that the psychiatrist said couldn't no way be a side effect. It couldn't be a reaction to the medication that he had put me on because it hadn't been reported. And that kind of brings another thing that you as providers and us as peer support specialists need to keep in mind. Just because there are reported side effects to a medication does not mean that there can't be other side effects that aren't reported or are underreported, because everyone reacts to medication differently. If we all reacted to medication the exact same way, there wouldn't be as many medication on the market for mental health conditions. And you know, just because someone experiences one thing with the medication, like for example, for me, I can't take Latuda because it actually makes me very suicidal. Whereas there are others that take Latuda and it works just fine for them. You know, so it's kind of important to keep in mind that when someone starts a new medication and they're brave enough to come forward about a side effect that's bothering them, that we as peer specialists and, you know, those of you that are providers don't just dismiss it as something that's not possible, because it's very possible that the medication is affecting the person the way that they're saying. And I do understand, you know, there are some programs that are only able to handle certain issues, but even in the sense of if something comes up as providers, you as providers that you aren't equipped to handle, the patient still doesn't deserve to be kicked to the curb like I was. You should do a warm handoff. It should be more of, you know, I understand you're reporting the side effect, and this isn't one that I'm aware of, and I am concerned that you might have some other issues going on that I cannot treat, and help and agree to help me or the patient find the appropriate resource to get them find the appropriate resource to help them get the support that they need, not just, oh, that's not possible. And so you have some other things going on that we don't feel comfortable with, and just kind of like kick you to the curb, more or less. So, after I got kicked out of IOP for the issues I was having, I'll give that provider a little credit in the sense that they gave me a list of people to reach out to, but they didn't really support me with finding a place to go. It was more of, here's a list and goodbye. Not, we'll help you find somewhere and make sure you get an appointment. And, so it was a little difficult, but I survived. So, my current therapist is the one I went to once I was kicked out of the IOP program I was in, because she has special certifications. When I first met with her for the first time, I actually felt listened to and understood about how scared and concerned I was with what I was experiencing while on a specific medication. And she was open to the idea that what I was experiencing is a side effect. So that was very helpful for me as a patient, that, here's a provider, and not necessarily, she's not a doctor, she's a therapist, she's a counselor, but still, even the counselor in the IOP program that I was kicked out of wasn't willing to take that chance or try to be open-minded to the idea that what I was experiencing was a side effect from medication. And then here I go to this new therapist, and she's completely open to the idea that what I was experiencing is a side effect. And she actually made me feel comfortable, and I felt listened to. And she actually applauded me for reaching out, and she said she wishes more clients she serves would do that whenever they're noticing something's off after either starting a medication, or they just have things happen in their life to where they manifest other issues, and getting help sooner than later. Another thing that my current therapist does that helps me feel supported and empowered is I have input on how often she sees me. I also know that if something happens and I need to see my therapist sooner, she will make that happen if her schedule allows, and not make me feel judged or ashamed about having to see her sooner. And this is something that's very important to understand, especially for peer specialists and providers alike, because the one thing you got to understand, especially when you're working or supporting someone with intellectual and developmental disabilities, with or without co-occurring mental health or substance use diagnosis, is those of us with IDD, we've already had our fair share of feeling judged or ashamed because of our disabilities. It's kind of one of those things like, just because I learned differently, people tease me, or, just because I can't walk and I'm wheelchair bound, which I'm not, but this is just an example, just because I'm wheelchair bound, people think that I'm a burden. Or, another example from my life would be, I wear leg braces to help me get around, and especially for playing sports like volleyball. And it's like there are times I go and I want to play volleyball, and I go, and then you know, there are people that don't want me on their team just because of my leg braces. And it's like, you know, it's hard. And you know, when those of us with multiple issues come in seeking help, the last thing we really need is to be made feel judged, like you're judging us, or ashamed that we're actually seeking help sooner. And with my therapist, this is very important for me, because of all the different issues I have going on, that it's very helpful for me to know that if I'm really struggling, I can reach out to my therapist and I can call her, and if she has time, she'll talk to me right then on the phone. Or if not, she has her office take a message and she makes sure to call me back. If not that day, she calls me back the next day. And then it's very important. I can't harp on this enough. For those of us with more differences than others, we don't need to be made feel judged or ashamed about having to be seen sooner. Because it's hard enough for us to reach out for help just because of the trauma we've experienced in our past because of our differences. I also have this exact same type of patient-provider relationship with my current psychiatrist. My current psychiatrist, who's also ironically the one I'm seeing since I got kicked out of IOB many years ago. Every time I go see her, I feel listened to. Even though we have a short visit, it's okay because I have the resources that I need, that I can handle short visits. But at the same time, my psychiatrist understands and would never do something like, if I were to end up inpatient and coming to see her when I just got out, she would never tell me, I'm only seeing you just because you just got out of inpatient. She understands that that's a major trigger for me because of my past. Feeling listened to is one of the most powerful things, especially for those of us with disabilities, because too often we don't feel heard, we don't feel listened to, and therefore whenever we try and get help and seek help, it's a big, we feel it, take it as a big risk because of our past. We don't know if we're actually going to get what we need, or if we're going to be made feel ashamed because we're needing help just because we're different. And also with my psychiatrist, if I have to go in sooner to see her, she might ask me, you know, what happened, but it's in a way that I feel supported, and I can tell she's genuinely concerned. I don't feel judged. I don't feel ashamed for reaching out and having to go in sooner. I feel that my provider genuinely cares about me and is thankful that I reach out when I need extra help, rather than just wait until things break down and then I end up in the hospital again. So, what is peer support? For those of you who may not know, peer support is person-centered, meaning that peer support is focused on what does the peer want. And I say peer, and that's just habit for me because I'm a peer specialist and we don't call the people we support clients. But this is, so for those of you with the clinical background, this would mean what is it that your client is wanting? What are their goals? You know, what do they want? Not what I think is best for them, not what their psychiatrist thinks is best for them. It's what the individual feels is best for them. Mutual. This means that there is no power differential. We're on the same level. Providers can never provide peer support because there will always be that power differential. That's kind of how come there are peer support specialists. We are individuals in recovery who have the lived experience of being in the same shoes as someone, and we walk alongside them in their journey and support them how they want to be supported. Notice I said support them how they want to be supported, not how I think they should be supported, not how their doctor thinks they should be supported, not how their therapist thinks they should be supported, not how their family thinks they should be supported. It's how the individual wishes to be supported. Evidence-based. There have been studies that have shown peer support specialists are able to develop a deeper connection with the peers that they support. And this is because of the lived experience. You know, when you have someone that's going through something, especially those with IDD, you know, they're more comfortable. I have been more comfortable around people who have been in my shoes than those who have not. And the kind of point about peer support is to help the person and they kind of understand that you've been in their shoes, so they might be more open-minded as to maybe, some ways that they can get the resources that they need. Strength-based. So, peer support, we don't focus on weaknesses. We focus on the person's strength. For example, when someone in peer support is reaching out because they're really struggling, we focus on that they're willing to they recognize they need more help, and we are proud that they have asked for help rather than, just stay quiet and just, suffer in silence. We focus on the positives. We focus on, what do you want to do? And it's not what I think you should do, it's what do you think you should do? And we really focus on their strengths, whether it be, they're very musically inclined, or they're very artistic, or they have a photographic memory. We kind of focus on the strengths to help them in their recovery. So, what is a peer support specialist? A peer support specialist is a resource broker. So this means that we as peer specialists, one thing we do is we build a list of resources available, and we share the resources with our peers that we are supporting. For example, if a peer comes to me and says, I really think I need to see a therapist, but I'm really struggling with finding one that, I'm just struggling finding one that is in the area that I can get to. Well, as a peer specialist, we are a resource broker. So one thing we would do is help this person find or get connected with a therapist that's within the area that they are wanting. Notice I said the area that they are wanting the therapist in, not the area that we just happen to know, or the area that we know of because of our lived experience. It's their area. Advocate. So as a peer specialist, we help those that we support advocate for their needs, whether it be by, if they would like us to attend their psychiatrist's appointment with them to help them feel supported and help them advocate, that is something we can do. If they want to learn how to do a specific skill, advocate, help them, reach out to, if it's not something that we as peer specialists can do, then, help them advocate to the proper person that can help them learn what they're needing. Or if they're needing housing, one, we're a resource broker because we, kind of connect them with housing, but then at the same time, if they're not feeling heard, we can help them advocate. But we're also at the same time teaching them how to advocate for themselves, because we're not going to be around forever. Peer support is not something that is, how do I say this? It's to help those in recovery get further along. Those that are just beginning in recovery, get to the point where they're functioning, they're able to find the resources on their own, they're able to speak up for their needs, they're able to find the supports and resources they need, and they're able to be a contributing member of society, whatever that meaning for them is. Motivator. So as a peer specialist, we kind of help motivate the peers that we support, help initiate change, but by supporting the peer. For example, a peer says, I really want to stop smoking. Well, then as peer specialist, or for me at least, the first thing I would say is, well, how would you like me to support you with that? Because it kind of shows them that, I'm genuinely interested in supporting them, and therefore it kind of helps them feel motivated. It helps them gives a little push for them to reach their goal. Or it might be they say they're going to do something, and then the next time we meet with them, we'll be like, so how did it go with the thing that you said you were going to do? For example, if a peer says, I'm going to reach out to my therapist and schedule an appointment because I really need to see them, then, we can either say, well, would you like me to support you with setting that appointment and help them right then? But the ultimate goal is getting them to do it by themselves, comfortable to do it by themselves. And then when they get to that point, follow up and be like, well, how did it go setting an appointment with your therapist? Problem solver when appropriate. So as peer specialists, we are not rescuers. We don't come to someone's rescue. We help people problem solve. And one way that I like to do it, and again, this is just me, other peer specialists probably have other ways, and that's fine. But for me, one way I help with problem solving is I kind of help them develop a pro and cons list so they can kind of see the pros or cons for some kind of, either decision or inaction. So for example, like what was they want to stop smoking. Okay, well, what are the pros of quitting smoking? And what are the cons? And kind of leave it to them to weigh the pros and cons. Because again, we're trying to get them to be self-sufficient to where they get to a point in their life where they're able to speak up for their needs. They're able to advocate for themselves. They're able to find the resources they need and obtain them. Ally confidente. So again, we're their ally. We're not, and I'll kind of get into this a little more on the next slide. We're not a spy for the treatment team. But whatever a peer shares with us, we hold in confidence. Confidentiality is very important. The only time that we really break confidentiality is if they're danger to themselves or others, or suicidal, homicidal. But being their ally, being by their side, role model. As a peer specialist, we're a role model. So we model the behavior of recovery. If you're a peer specialist and you're going out to a bar and you're getting like completely drunk and to the point that you're like staggering and someone recognizes you as a peer specialist and they see you like that, that's not really being a very good role model. So as a peer specialist, we're a role model for what recovery looks like. We demonstrate and show, what is recovery. Truth teller. So another thing as a peer specialist is, we're the truth tellers. We kind of tell it like it is, but so we don't sugarcoat it, but at the same time, we don't like make the peer that we're supporting feel like really low and like they're worthless. We're just upfront and tell them, from our experience, what worked for us and what didn't. And, whether they listen, is up to them. All we can do is be honest about our lived experience and what we did in similar situations to the peers we supported. And then it's up to them to decide, whether they're going to take a similar approach or do something completely different. What a peer support specialist isn't. And both of these this is not an exhaustive list. These are just kind of the main examples. We are not a therapist. Peer support specialists are not a therapist. We do not do CBT. We do not do DBT. We do not do EDMR. We do not do any type of therapy, period. That is outside of the scope of our ethics. We do not have the training to do therapy. We just don't. We are not a spy for the treatment team. This means those of you that work with peer specialists, please, as providers, please, please, please don't be asking us peer specialists to be a spy and be like, finding out information you're wanting to know, like, is Johnny taking his medication? Or we're not an enforcer either, meaning you really shouldn't be telling us to tell our peer, for example, we're in treatment team meeting and psychiatrist is saying to me, you need to tell Johnny either he becomes med compliant or he won't get peer support anymore. We're not an enforcer like that. That is not how to to properly use peer specialists. We as peer specialists are here to support by helping the peer or your patient, but I call them peers, helping the peer learn how to advocate for what they want, for what they need. You know, and if they're having issues with medicine, helping them, support them, and how to bring it up with their treatment team. So we are not a spy. We're not a spy for the treatment team. We are not the ones to go and like try and ask questions and report back like med compliance. It's a fine balance. We're there to help support the treatment team, but at the same time, we're there to help support the peer. And if the peer is sharing stuff with us in confidence and not wanting us to share it with their treatment team, then we as peer specialists need to honor that unless they're like suicidal or homicidal. We need to honor that, because if we end up being a quote spy for the treatment team, then they're not going to be open and honest with us. And it's going to be harder for us as peer specialists to help them get to the point in their recovery where they're able to navigate things on their own, where they're able to get the resources they need on their own. They're able to get the supports they need. They know how to reach out. And so we're just not a spy for the treatment team, but we are there to help support. Peer specialists are not someone to do clinical intake assessments for treatment. Again, that is outside our scope. We do not have the training and knowledge to do clinical intake assessments for treatment. We can do a recovery plan, and we can talk to them, you know, what does recovery look like to you? What are 2 of your goals that you're wanting to meet while working on your recovery? We can do assessments like that, but we cannot do clinical assessments for treatment. We cannot, and we should not be doing those. All right, so now we're at how can peer support benefit those with IDD? So first off, providing individuals with IDD support with social skills development. Right now, in the state of, at least in the state of Texas, if you do peer support through like MHMR, you will only qualify if you have a mental health or substance use diagnosis. And that's how I qualify for peer support. I have the mental health diagnosis. When I went through peer support myself, while yes, I did have the support for my mental health, I had no support for any of the social skill development delays that I had, like the understanding appropriate boundaries, understanding how to recognize red flags, how to read nonverbal language, appropriate responses to different situations, appropriate interactions within different social settings. Those were all things that I had, and guess what? They all affected my mental health. But yet, because they were IDD related, I got no support. And therefore, it took me longer to get as far as I am in my recovery. You provide individuals with IDD a group setting to give and receive mutual support from others with similar struggles. I can't tell you how many times in different support groups that I have done with different agencies like Reach of Plano, that I've been told by people with IDD who may or may not have had a co-occurring mental health or substance use diagnosis, all they really want is a group to attend for support of people like them that go through similar struggles and understand what they're going through and able to get support. That's all we really want. You know, the individuals with the IDD, just because we're a little more complex doesn't mean we don't deserve the same treatment options. It doesn't mean that, oh, you are a little more complex, so you can't have access to a support group of others that have similar struggles as you, so you can receive and give mutual support. That's not fair. And that's more or less what's happening in Texas, at least with the MHMRs, from my understanding. If you don't have the mental health or the substance use, then you're not really getting peer support. You might get social skills training, which is also another important thing, because the social skills training helps you with daily living skills, how to cook, how to go grocery shopping, and things along that line. But at the same time, if you don't address the other issues and do it where they have the supports that they would like and are asking for, then we're not really setting them up for success like we are for those with just mental health or substance use. Provide individuals with IDD the opportunity to learn how to advocate for their needs. That is another thing, as I explained earlier, that we as peer specialists do. We help the peers we support learn how to advocate for their needs. And just because someone is a little more complex doesn't mean that they don't understand what their needs are. It doesn't mean that they're incapable of asking for what they need. It doesn't mean that they don't deserve to learn how to advocate for their needs. And I also know, one kind of thing that comes up sometimes is, well, not all people with IDDs are able to talk. But does that really matter? Are you saying, can someone with IDD not communicate, or are they communicating a different way that you aren't just taking the time to understand? For example, my best friend since 6th grade has Down syndrome. He would be on the lower functioning end. He can bathe himself, that kind of stuff. But communication, he's not really able to do outside of like 1 or 2 word replies. And so one way I know when he's ready for lunch, as ridiculous as this may sound, he actually starts doing flapping his arms like chicken wings, because chicken is one of his favorite foods. And that's how he communicates to me that he is ready for lunch and he's ready to eat. Another way he communicates with me on what he wants, when he's ready to play Wii, because he has a Wii and he really loves playing football with me, he will bring the Wii remote to me. So just because someone with IDD can't speak verbally doesn't mean that they're not able to communicate another way. Another example from a summer camp that I worked at for those 4 kids with special needs, we had a camper who in the past was traumatized, and one way that they expressed that they were traumatized because they couldn't speak, they're nonverbal, is they would do things to show that they were in control. And at this camp, the particular way she kind of communicated she was not okay is she kept going in the room we had the DVD player in, and she kept messing with it because to her, she had control over the movie. And that was her way of trying to communicate with us that something had happened that made her feel not okay. So again, just because someone with IDD is nonverbal doesn't mean that they can't communicate. It just means that you might have to learn their way of communication. People with IDD who receive services from the Home and Community-Based Services HCBS waiver are required to have a person-centered plan that outlines outcomes and action steps, which peer support can help meet this requirement. By starting to offer peer support to those with IDD, you can meet a state requirement. I don't know if y'all realize that or not as providers, those of you that are providers, but your clients that are in HCBS waiver programs are required to have a person-centered plan. Peer support can help with that. Peer support can help because peer support is person-centered. And peer support can help the person figure out what outcomes they're hoping to have. Like, for example, if they're wanting employment, or what kind of employment do they want? And then the action steps, we can help them, support them in, okay, Johnny, if you want to be a waitress at Chili's or a waiter at Chili's, what do you think are the steps you need to take to make that happen? And we can document that. That's just something to think about. Help those with IDD discover and develop their voice so they are comfortable speaking up for what they want in their treatment plan. This is something that took me a long time because I didn't have proper supports. And it took a while to get the supports that I needed. But I can't tell you, as someone with intellectual and developmental disabilities with co-occurring mental health diagnoses, figuring out my voice and being able to have a say in my treatment plan has been one of the most empowering things. It's what gives me hope that I will get better. There's hope for me getting better. There's hope for me meeting my goals. And you got to understand those with IDD, just because they're typically treated differently, they're not going to be very comfortable at first speaking up for their needs. They will know what they need, or they'll know what they want, but they'll be hesitant to ask because of previous trauma. So by offering them peer support, we can help them get past that and learn that, they do have a say in their treatment. Because when you think about it, when you go to meetings, it's this person's treatment plan. It's not Dr. So-and-so treatment plan. It's not therapist so-and-so treatment plan. It's not peer specialist treatment plan. It's not family members treatment plan. It's an individual's treatment plan. Therefore, they need to have a voice. They deserve to have a voice in their treatment plan, just like those with mental health and substance use have a voice and what they want. Those of us with IDD deserve the same. We deserve to be able to have a voice in our treatment. So some of you might be thinking about, well, where would this funding come from? One option for funding is to reach out to Texas Health and Human Service Commission and Intellectual and Developmental Disability Department and say you want part of the funding from exceptional item 22 to go towards peer support services for individuals with intellectual and developmental disabilities with or without co-occurring mental health and or substance use diagnosis. For some of you who may not be aware of this, back in the 2019 legislative session, Texas HHSC was awarded funding specifically for outpatient behavioral health services for individuals with intellectual and developmental disabilities. Part of that funding has been awarded to 5 local IDD authorities, which I have been working on advocating with to expand peer support to those that are in the program that they're using this funding for. So there are funding options. All right, so the Texas Medicaid peer support certification. So in Texas, back in 2019, you had House Bill 1486, which is the bill that finally made peer support a Medicaid benefit. From that bill, there came 3 certifications. The mental health peer specialist, which is what I hold, and is for those with the lived experience with mental health. Then you have the RSPS, which is the recovery support peer specialist. This is the certification for those with lived experience with addiction. And then you have the PSS, the peer specialist supervisor. The peer specialist supervisor is the one who would be signing off on the required 250 experience hours, as well as doing supervision in general. And for more information on these 3 certifications, you may visit the link that is shown. So that concludes my presentation. We can now enter the Q&A session.
Perfect. Thank you so much, Jordan. That was wonderful. And I think you answered some of the questions that we had submitted ahead of time throughout your presentation. We still do have quite a few. So I'm going to let the audience know that if we don't get to your question during the next 30 minutes, then we may be able to follow up afterwards. I will email Jordan those additional questions and see if we can get some responses back to you. So before we get started on this Q&A, I'm going to go ahead and release a poll that we have to send out. And we will also send out the evaluation for the CU at the end of the Q&A. So please stick around for that. So real quick, I'm going to go ahead and submit this poll. Everyone can please respond before we move forward. That would be great. It's just a 1-question poll. Thank you. Okay, I'm going to get started on the Q&A. So Jordan, we had multiple questions asking about what type of certification you had, what entity provides those certifications, and I think you gave some of that information to us already. Some of the questions we received are about how peer support can be particularly adapted to working with individuals with IDD, and I think you gave some good examples already. But if you wouldn't mind giving some examples about how peer support may be provided to someone who has more limited cognitive functioning. So let's say instead of explaining necessarily all the different ways that a peer support works in the way that you just explained it to us, how might you adapt some of that information when working with somebody with IDD?
So the first thing that would be important is whoever the peer specialist is needs to be comfortable working with those with disabilities. Because if they're not comfortable, which is totally fine, because not everyone is comfortable working with those with disabilities, it's fine, but it's not going to work if you don't make sure whoever is providing the support is comfortable doing so. So this isn't something like at an agency, you just all of the sudden assign people with IDD to your peers. You would need to first have a conversation with your team and make sure you understand who is and isn't comfortable supporting those with disabilities or special needs. Because otherwise, you're just, if you try to stick someone who isn't comfortable, you're either going to traumatize them or you're going to traumatize the individual with special needs further. And that's just not fair. So that's kind of the first thing about adapting it. And that's kind of the biggest thing, really. You really need to make sure whoever's providing the support is comfortable working with that population, because it's just going to save a lot of headache for you down the road. Than if you were to just like automatically start assigning people. Be open-minded to trainings, because again, just because someone is comfortable working with the people with IDD doesn't necessarily mean that they have the lived experience. And if they don't have the lived experience, then it's going to be a little more difficult for them to connect, but it doesn't mean that they can't. So just kind of be open-minded about that. If you're going to adapt peer support to those with IDD, ideally it would be someone with disabilities supporting someone else with disabilities. But here in Texas, that's not widely done yet. And I think we'll get there eventually. And we actually have a bill this session, Senate Bill 1457, which is to make peer support a Medicaid benefit for those with IDD. Is by Senator Zaffirini, who I have reached out to earlier this year to see if she was going to refile it from the 2019 session, and she agreed to, and it's been filed. And so we'll kind of see what happens. So it's kind of like, if you're going to adapt it, you need to first make sure whoever's doing the support is comfortable doing so and doesn't feel obligated to do so, because if that's just not going to work, they have to genuinely want to support people with special needs, or it's not going to work out. It either won't work out for them because they'll get burned out because they get frustrated, or the person receiving supports will pick up on the sense that this person doesn't really care or isn't comfortable, and then it kind of makes the person receiving supports feel like a burden to the person providing the supports. Because it's like, the one thing you kind of got to understand is with some people with IDD, we can kind of pick up on when someone is or isn't comfortable around us. And then it's like, if they're the ones providing us support, but we kind of pick up on the sense that they aren't really comfortable doing so, it kind of makes us feel like a burden by being open with them. Because then it's like, well, we're trying to get the supports we need, but then it's like, this person isn't really comfortable, so maybe I should just stop sharing. And that's not the point about peer support. It's mutual, and it can't be mutual if both parties aren't comfortable. So, just kind of make sure it's a good fit, and then keep open-minded to training opportunities.
Mm-hmm. Definitely. Thank you, Jordan. Those were really useful examples. And thank you for telling us about the bill that's going to be resubmitted this session. Okay. So real quick, I'm just going to answer. There were a couple of questions about sharing this recording. Yes, I will be sending out a link for individuals to be able to view the recorded version of this presentation later this week. It will take a minute for it to be ready. Just wanted to let people know it will be available. Unfortunately, we don't have the ability to track if someone has viewed the entire session for CEUs unless they were attending it live. So please reach out if you have any questions about that. Okay, So I'm going to go ahead and move on to another question. We have a kind of a two-part question, I think, that we can put together, Jordan. So asking, what is the best part of being a peer support for you? So what's your favorite part? And then what's the most challenging aspect?
So my favorite part is also kind of the most challenging, actually, because my favorite part is supporting others with disabilities, but it's also challenging because it's not really widely done in Texas yet. So it's my favorite part because that's my passion, but it's also a challenge because it's like we got to close the gap here in Texas that exists between treatment options for those with mental health / substance use and those with IDD.
Definitely. Okay. Thank you. It sounds like you have a strong passion for advocating for quality services for this particular population with co-occurring needs. And it sounds like you've had a lot of ways that you found to be useful for yourself and for others. Okay, next question. Peer support provides practices to support individuals who are in recovery. And the question was about what might be some good peer support practices during a crisis intervention.
Okay, so, I'm going to assume they mean in general since they didn't specify.
Not a particular case, but
okay, so in general, in crisis, make sure the person feels supported and listened to. And one way you can do this is by reflective listening. So like listening, but then every so often stop and say, okay, so what I think I hear you saying is this. And but what I do is a little more comprehensive. It's like, so I want to make sure I understand what you're saying. So what I think I hear you saying is, and then I tell them what I think I hear they're saying, and that gives them the chance to either say yes or no. And typically, if they say no, they'll go automatically start explaining is the typical response. But if they're not, like after they say no, if they're just kind of not saying anything, ask them for assistance and understanding what they're trying to say. Another thing that I have done in general crisis, kind of ask them, what they kind of notice about themselves when they're in this type of situation. Because sometimes this isn't the first time they're in crisis. And so depending on how far in the crisis they are, they can potentially give you information. For example, I was helping someone in crisis, and the one thing they had shared was they noticed that when they're not getting enough sleep, they're more paranoid, but they hadn't spoken up to their doctor yet. So I kind of picked up on that. And then of course it's following up and be like, well, so you've noticed that, when you don't get enough sleep, you're more paranoid, but you haven't talked to your doctor yet. Do you think this is something that might be, do you think sharing this information with your doctor might be helpful? And sometimes they say yes, and sometimes they say no. And then, just kind of take it from there. Just always make sure they feel heard and listened to and supported, but don't be afraid if it kind of gets over your head to ask for help. And the way that I have been trained to do that is explain that you're there to listen and help them feel supported, but you're needing a little assistance, and so you're going to reach out to your supervisor. that's kind of the way I've been trained to handle that kind of situation where it's now over your head, but you don't want to make them feel ashamed for being so open. Because sometimes in crisis, being very open is what leads to them getting the support that they need.
Definitely. Thank you, Jordan. That's really helpful. I'm going to go ahead and release the evaluation for the Hub Learning community. This is not the same evaluation for CEUs. Please go ahead and complete it. It is pretty brief. And then we're going to transition into a few more questions about next steps and what our audience can do to support peer support services for individuals with IDD. So please look in the chat. Okay, Jordan, we have a couple questions that have to do with what we can do next in the community and how we can partner to provide more education and advocacy. So the first question we have on this topic is, how can we provide this education to local communities and stakeholders? And I believe when we're talking about this education, that's in reference to the information you've provided us today. How can we share that with other communities and stakeholders?
Well, I'm going to put this presentation on my website, which is on the current slide. So you can always send them to my website, or they can always reach out to me and I'll be happy to do this presentation. Always, you can advocate for SB 1457. That's kind of one of the biggest things you can do, is to help get that bill passed so that services can start. Or we can at least get the process started.
Mm-hmm. Perfect. And how would people advocate for that bill?
So reaching out to different organizations like Texas Advocates, Texas Parent to Parent, NAMI of Texas, MHA. You can also reach out to your local legislative representative, either your House representative or your senator, and tell them that you would like this bill to be passed, or at least be put forth to a vote.
Perfect. Thank you. That's really helpful. And the next question was actually about what some of those organizations might be. So I think you're kind of transitioning well into that item. So would you say—
you could also advocate to Texas Health and Human Services Intellectual and Developmental Disabilities Department. That'd be another place you could reach out to.
Perfect. Thank you. So one of the other questions we had received before this presentation was about locating support groups for people with dual diagnosis, so with IDD and another co-occurring mental health disorder. So I wonder if that's something that you might be able to speak to a little bit, Jordan, is where might support groups be?
Okay, so right now, the only ones I know about, and my apologies for accidentally exiting out of the PowerPoint presentation. I didn't mean to do that.
No problem.
But Reach of Plano, Reach of Dallas, Reach of Fort Worth, and Reach of Denton all do peer support. So basically the independent living centers here in Texas are the ones that typically do peer support for those with IDD and mental health and or I would think substance use, but I'm not 100% on that. I know for sure IDD and mental health, because I did a group at Reach of Plano, and that's what our focus was. There's Reach, I guess the best place for you to go is Google Texas Independent Living Council, or type in Texas Independent Living Centers, and it should pull up a list. But those are the ones that typically do it as of right now, which is what I'm trying to change. Not that I don't want them doing it, because I do, but it's like there's only so many independent living centers and they can only service so many people. So it's like we need to start getting the LMHAs and or the local IDD authorities to start offering peer support, because just having independent living centers isn't enough.
Okay, thank you. We did get some responses during the presentation about some of the services that are being offered by different groups, who our participants are connected to. So one example is with Imagine Art, which is a HCS and day hub provider here in the Austin area. They are creating peer support groups for people with specifically IDD labels. It's called Training for Transformation. And so that's some information I can send out as well. I'm sure some people have received those informational emails. And then we also had a response from the MHMR of Tarrant County regarding some of the adaptations they've made recently for the criteria of their services. So those changes, therefore, making it possible to serve people who may have specific needs related to IDD as well as mental health. So that's really helpful. Thank you for everyone who provided that information. And if you have follow-up questions, you can email the HLC, it stands for Hub Learning Community, hlc@integralcare.org, and I can give you some of this information that has been provided today. Okay, Jordan, let's see. I think we have time for 1 to 2 more questions. Sound good?
Yeah.
Okay, so we had another question about your personal experience providing peer support, and if you have found it relatively easy to relate to people with varying degrees of cognitive capacity. So you yourself, if you feel like you can relate to people who have all different levels of cognitive capacity.
So it's been a very interesting experience, in the sense that I find it a lot easier to provide peer support to those with IDD than those with mental health, just because a lot of my issues are from IDD perspective. And it's not to say that peer support in general for IDD, mental health, and substance use isn't important, and not that I can't do it, because I can. It's just my experience has been it's a lot easier for me to do peer support for those with IDD, because I understand the struggles that they're going through, and I actually have materials over topics that they're typically interested in. And so it's like I've kind of already got the materials just because of things that I have been through, or resources people have sent me because they know of the different struggles that I have. So hopefully that answers your question.
Yes, I think it did. So I hear you saying that you can relate more to people who may have both IDD and co-occurring disorders, or solely IDD, because that more closely mirrors your experience.
Yes.
Okay, sure. What a great resource you are then to those people who may not always be able to find someone who matches their experience. Let's see. Okay. We also had a question about how you might inform providers about services and supports. And I am not sure if that's only in reference to medical providers or perhaps other types of service providers, but essentially, how would you let those who work with people with mental health disorders, how would you let them know about peer support for people with IDD? How would you?
Kind of do what I've been doing during my outreach with the 5 local IDD authorities, just kind of emailing them, sharing a little bit of my background, and pretty much just asking for an opportunity to meet with them to talk about it more. Because the one thing I don't want to do, or that people typically don't want to do when trying to share a resource or a new option, is overwhelm the receiver. So I've found it pretty effective to kind of reach out via email, kind of share a little bit about my story and why I'm emailing them, and then just ask for a time to meet with them. So that's kind of been my approach, and it's been pretty successful. So that's probably one of the things I'll stick to. And then as I'm working for an organization right now, they don't do peer support for IDD yet, but making networking is kind of another way. I've kind of done this. It's like finding providers of different services that might be helpful, and then kind of trading information.
Definitely.
Networking, emailing,
Yeah.
social media.
Mm-hmm. Sounds like you have a lot of experience with different kinds of advocating, but also just building awareness overall for what services can be available, perhaps those that don't exist that you would see a use for in our community. It's really helpful. Thank you. Okay, Jordan, I think this will be our last question that we have time for today. We had a question about what trainings you found most helpful as a peer support specialist. So are there particular trainings that you have found to be most useful?
I like the MHPS training. That was helpful. The mental health peer specialist, the peer recovery support specialist training through MHMR of Tarrant County. That one was helpful. I did a group facilitation training through Via Hope, which was helpful. And then kind of sort of went through trainings with Reach of Plano, sort of in a way. And so that was helpful. With Reach, it was more of kind of what they do and what they do is in regards to peer support. So it's kind of like learning a different way peer support is done. Was kind of an interesting experience, even though it's not that different from how people with the MHPS or other that are certified specialists. That's kind of the other thing I'm hoping to change, is getting those that are providing peer support to those with disabilities, making sure they understand that there is a certification available so they can get more training if they so choose.
Great, thank you. It sounds like you've taken quite a few, and those are really useful resources. It's possible, Jordan, I might reach out and get some of those listed in writing. I didn't have a chance to write them all down, and it sounds like people could definitely benefit from those. We've received a lot of submissions to the Q&A that are just thanking you for your presentation and for sharing your experience and how helpful it's been. Just wanted to give you that, and I'll share some of that feedback with you afterwards as well.
Okay.
Yeah, thank you so much.
Thank you for having me.
Of course, yes. I want to make sure everyone knows I'm going to go ahead and send out the CEU evaluation link now. And that'll be the last thing I send out in the chat. So feel free to go ahead and open that up and complete it before you leave today. That way you'll be able to receive your certificate. Okay, well, one more time, Jordan, thank you so much for joining us and for sharing so much about both your personal and professional experience. I think it's benefited everyone. Yeah.
Okay.
Okay.
Thank you for your time.
Yeah, and thank you everyone who's joined us as a participant today. We hope you'll join us for future opportunities as well, and just be aware that there will be a recorded option sent out after today. Okay, I'm gonna go ahead and send that CEU link. It's in the chat box now, and I will go ahead and stay on to make sure everyone has access to that link for a couple more minutes. But other than that, we are completed with our training. So thank you so much, and thanks, Jordan. Bye.
No problem.